Hi guys, and welcome back to the Report Radiographer channel. My name's Nick Barlow, and today we're going to be talking about image interpretation of the shoulder. And this video is mainly aimed at students and newly qualified, so I'm not going to be going into loads of detail. It's mainly just looking at the anatomy and the basic principles of how we read the shoulder x-ray and some common pathologies that we'll see. I am going to be doing a PowerPoint for this just because there's a few information slides. But as always, guys, feedback of the image quality. The images look okay to me on my computer, but it depends what device you're using. So if they come up a little bit blurry because of the PowerPoint, just drop us a comment and I'll change back to just doing it on the PAX platform. But for this one, I thought it'd be best to do a PowerPoint. So without further ado, let's get into it. So the shoulder girdle, just looking at the anatomy first, you've got the bony components. So you've got the proximal humerus, scapula, and clavicle. And then you've got the various muscles, ligaments, and tendons surrounding them. And I'm going to be focusing on the rotator cuff. So this comprises of 4 muscles and respective tendons. So we've got the subscapularis anteriorly, the infraspinatus posterior superiorly, the teres minor posteriorly, and the supraspinatus superiorly. And we've got a diagram in a minute just to show you visually where those are. The common injuries of the shoulder that we'll be looking for in children, particularly clavicle fractures, because the clavicle, it's long and thin bone, more susceptible to fracture. As you get older, you get more dislocations seen, and then in the elderly, you get proximal humerus fractures, usually associated with osteopenia and osteoporosis from falls. So we'll just have a look, guys. I've got my point here. This is the rotator cuff. So teres minor comes in here anteriorly. This is the proximal humerus, humeral head, and this is holding the humeral head in place at the glenoid, basically. And you've got the 4 muscles doing that. Subscapularis posteriorly, supraspinatus that runs up here, and then infraspinatus that comes around the front as well. So what views are we going to undertake? So the first one is always the AP view. Always required as a first view. Now, sometimes you would do it straight. Sometimes if you were wanting to assess the glenohumeral joint, you can do it rotated by around 15 degrees. If you rotate the patient outwards, you can see into this joint a lot clearer. Okay. The offshot of that is you can't always see the AC joint clearly. So it depends what you're looking for. Sometimes you could do a straight AP and a turned AP. Sometimes people just do one AP view. But you can use this to detect fractures and dislocations as well. But as always in radiography, we usually need more than one view to be able to see what we need to. So usually you would do what's termed an axial view. And this is preferred in trauma situations because it's really good to be able to see, to look for dislocations. So routinely you would have the patient sat down, you would bring their arm out to the side and you would take an x-ray from the top down. Now, sometimes with patients in trauma, they can't move their arm sufficiently to be able to do that. So you could do what's called a modified axial, where you would angle down and out 45 degrees. But we're essentially assessing for any dislocations there. Can also identify any fractures as well. Very good sometimes for seeing coracoid fractures. So the coracoid comes up around here. So quite hard to see on the AP view. So by looking at it here, from this perspective, this is the coracoid here coming around the front anteriorly. So good for seeing fractures there. You can also see, as well as the greater tuberosity, which we can see on the AP view here, we can also see the lesser tuberosity, and we can assess for any fractures or issues there as well. And we've also got the Y view. Now, the Y view is really good, again, for assessing dislocations and also any issues with the scapula. You can also look for calcifications here, posteriorly as well. And we'll get onto calcifications later. But it's only a good view if the positioning's right. And the problem is with this, you've got to get it spot on. If not, then it's rotated. And even in this image, the blade of the scapula is off. Normally, it would be a nice thin blade of the scapula coming down there, but this one's slightly rotated. And it can be difficult, particularly in patients who, trauma patients, again, really difficult mobility, can be very, very difficult to get this view right. So it's only useful if it's a true Y view. Okay, so here we've got an AP view of the shoulder. And as I said, This glenohumeral joint, we can't really see that too clearly because of the patient position, but we are seeing that AC joint space really nicely there. We can also see this subacromial space nicely as well. So we're going to be looking for any calcifications there and a narrowing of the joint space. Generally, when we're reporting x-rays, we do so in a systematic way, just so we know we're not going to miss any key areas. So apart from checking the necessaries, the patient details, making sure the x-rays are actually for the correct patient and you've got your markers on, this one's being added in post-processing. Once you've checked all of that, you're checking the bony structures so you can sort of trace around the outline of the humeral head. Does it line up well with the glenoid? At this underside, it should be a nice smooth line coming over there and down, which this one is. You can assess the joint spaces. Assess for soft tissues for any calcifications. This here is the acromion here coming round. The coracoid is here, so not really clear to see. You can look for any cortical irregularities though on this view. We've got the acromioclavicular joint here. This is clavicle here coming across. Sternoclavicular joint here. You can do sternoclavicular joint views. I notice a lot of patients are going on to CT rather than these views though, because they're getting quite difficult. Unless they're done perfectly, it can be quite difficult to visualize in the joint. Some places still do x-rays for sternoclavics, some do CT. Just depends what your protocol is. Don't forget to check the lungs as well and the ribs, particularly in trauma. Sometimes these really good view actually to assess the ribs and for any fractures. Sometimes they'll come in with a shoulder x-ray and a chest x-ray, and this view is much better for visualizing those ribs and looking for any fractures. And you'd be looking for potential pneumothoraces as well. So don't forget to check the lungs. And the remaining soft tissues as well, just to make sure there's no masses, there's no other calcifications, there's no subcutaneous gas or any foreign bodies or anything like that. So this glenohumeral joint, as I've said, can be quite difficult to assess unless the patient is rotated outwards slightly. AC joint, you wanted to make sure that the inferior aspect of the clavicle lines up with the inferior aspect of the acromion there in a line. So not too bad. I mean, I've drawn it crudely across there, but basically you just follow that across and that lines up okay on that view. On the axial view, what we're looking at. So this is a humerus. This is a humeral head coming around here. This is the anterior aspect. This is the front of the patient. This is the posterior aspect. And this is the acromion coming round here at the back. The coracoid comes round at the front. This here is a glenoid. And this is a glenohumeral joint. Here is the AC joint. You can't really see the AC joint clearly on this view because of the overlying bone. And this is the clavicle coming in here. Can't really assess the lungs on this projection. It's more about assessing the glenohumeral joint. If it's a GP patient, say, coming in with arthritis, really good view for assessing that. If it's a trauma patient, you're looking for fractures and dislocations. This is a modified axial. You remember, guys, when I said about the 45-degree out and down? It used to be called a Gratier view where I was, but it's called all manner of different things. But basically, it's just trying to get as close to that axial projection as possible. So again, we've got acromion coming in here from the back, coming over the top. This is coracoid process coming out at the front. We've got the glenohumeral joint here. This is the glenoid. We've got a fracture here coming out at the posterior aspect of the humeral head. But we've got no dislocation there. You see that lines up nicely with the glenohumeral joint. Some more labeling for you on this Y view. So again, this is slightly rotated, guys. So we just should be seeing the side, the blade of the scapula. This is very slightly rotated, but not bad. It's not a bad view. It can be very difficult to get these perfect. But we've got clavicle coming in here. This is the AC joint. Acromion coming in at the back, coracoid at the front. This is a glenoid area here. This is humeral head, proximal humerus coming down. This is the blade of the scapula. Keep an eye out for any fractures, particularly towards the inferior angle of the scapula. Really good for assessing dislocations as well. So just keep an eye out for where that humeral head is. It should sit over the glenoid here. The glenoid is here. Just tracing the outline there. And just remember just to check the lungs there. You're not going to get a large portion of the lungs there because of collimation, but it's always worth checking them. And of course, the soft tissues for any foreign bodies, etc. So, on to the first bit of pathology. So, commonly, when you're doing the shoulder, it's either for arthritis or fracture. And proximal humerus fractures generally arise within most fractures would arise within the weakest point, and typically that'd be around the surgical neck area. So, they involve one or all of the four major segments, okay, of the proximal humerus. So this is what the surgeons use when they're kind of interpreting the fractures and what they need to do and the severity and stability of the fractures. So you can either get a one-part fracture, so that involves one to all segments with minimal displacement. But as you get to two-part, three-part, four-part, the potential for dislocation and instability increases. So 2, 3, and 4-part fractures, they have a higher association with anterior and posterior dislocations because it's multiple segments are affected with increased displacement. The fractures may be pathological, so they may be due to tumours or it may be trauma related. I'm not going to go into too much detail on this. It was just a little bit of background. But basically, if we look here, we've got a fracture here involving greater tuberosity, comes up here, round, and it's only mildly displaced. And we can see here, this glenoid here kind of lines up with the humeral head, so there's no dislocation there. If it was anterior dislocation, this would come forward. This humeral head would come medially forward. Posterior dislocation tends to look more like a light bulb shape. It kind of rotates, and it's quite difficult to see on this an AP view. Posterior dislocation, usually need an axial or a Y view for that. We'll talk about that later. Clavicle fractures usually lead to inferior displacement of a distal component. Common sites are the middle and distal third. The proximal end of the clavicle is not commonly affected. In my experience, it's usually the mid shaft. Need a full AP shoulder as well as an axial, though. One view isn't normally sufficient to be able to evaluate clavicle fractures sufficiently because you want to determine the degree of displacement. You also need to be able to see if there's any rib fractures, any pneumothoraces, any secondary complications to this. So one view isn't normally sufficient. Although I am seeing in practice more and more just single view clavicles being done. But personally, you need two views. Here we've got a comminuted fracture, mid to distal shaft. We can see we've got an avulsed fragment here and a smaller fragment here. And then we're looking for any potential dislocation at the AC joint. We can see we've got the underside here of the acromion marries up nicely with the underside of the clavicle. So there's no dislocation there. There's no associated bony lesion or anything to suggest that this is a pathological fracture. Obviously, you'd marry it up with the patient's clinical history for that one. Doesn't look to be any rib fractures. Can't see any signs of a pneumothorax. So you'd be looking for a pleural surface and then a lack of lung markings beyond that, but we're not seeing that. You can, if you was to zoom in, you can see some faint lung markings up here. So no signs of any pneumothoraces or anything. It's just that comminuted fracture to the clavicle. Here's another example here. So we've got a displaced fracture. Again, we're not seeing any dislocation there at the AC joint, but we are seeing significant displacement of that fracture with an avulsed fragment. So this is still a comminuted fracture. The temptation is to kind of end the search there because you think, right, well, we've identified the problem. But what you must do is keep looking. You can see here we've got some irregularity to these posterior ribs here. So we've got some rib fractures. And then when we zoom in up here, we can faintly see, and you probably have to take my word for it on this one, guys, but you can faintly see a pleural edge there with no markings in this section beyond. So we've also got a pneumothorax. If that wasn't enough, we've also got a scapular fracture coming in here. You can see we've got some cortical irregularity and some lucency here, probably coming down and through the blade here, but difficult to see the rest of it. We're only seeing this this aspect here. And then Like I've said before, we need to assess the AC joint for dislocations. And acromioclavicular injuries, usually from a direct blow or fall into the shoulder with an adducted arm. AP and axial views are enough to quantify, and often you can determine the level of displacement on an AP view, but you can also perform weight-bearing views. If the initial radiographs are normal, but they're still suspecting there's an injury there, you can actually get them to hold a weight if the patient can actually stand it, and that can sometimes emphasize any instabilities. Sometimes they'll do it for surgical intervention as well. So if they're planning surgery, they'll do normal, neutral AP, and then weight-bearing views. And it's commonly graded as something called a Rockwood classification. And I've got a little diagram here to show you. You don't need to go into too much detail again about this. It's more important, really, for you guys that you be able to spot whether there is a dislocation. You don't need to grade it, but these are just the different types. So type 1, there's no elevation of the clavicle with respect to the acromion. There's just a little bit of widening there. Type 2, you start to get some elevation of the distal clavicle, so you get a step in that alignment. Type 3, it's elevated beyond the superior border of the acromion. Type 4, it becomes displaced posteriorly into the trapezius. Type 5, it's markedly elevated. And then type 6, the inferior clavicle actually becomes inferior displaced. Okay, so different directions of displacement, different gradings, but the important thing is you can recognize if there is a displacement. If there is, it suggests that there's some ligament instability, ligament damage. Scapular fractures. So these are less common and often difficult to spot because you've got loads of overlying bony structures. Fractures of the glenoid rim and fossa are important to identify because of intra-articular extension. So often, if you got a dislocation, for instance, the temptation is to say, right, I've seen the problem, like exactly what I was saying before. You see a dislocation, you think, right, that's it, we've solved it, we know what's wrong. We forget to look for the secondary issues, but it can have a major implication on that patient's treatment. So it's really important to look for these secondary fractures. Other fracture sites, the coracoid process, so that's probably best seen on the axial projection, acromion process, surgical neck and anatomical neck of humerus, sometimes the spine and the body. So lots of different areas to focus on. Scapula best really evaluated on the Y view and an AP view. But as I was saying, if you don't get that Y view right and it's rotated, often all you'll see is just subtle irregularities in the cortexes or subtle steps. Can be very, very difficult sometimes to see the actual lucency of the fracture when it's rotated. You can get fractures to the anterior aspect of the inferior glenoid rim. Now, this is known as a Bankart lesion, which I'll show you in a minute, which may occur secondary to anterior humeral head dislocations. Okay, so this is an example of a body of scapular fracture. It's comminuted fracture. We've got a small avulsed fragment here, but we've also got, if you follow this cortex down, we've got a step there, and we can also see some lucency there. Here, this is a patient that had dislocation that it's been reduced, and you think, oh, it's brilliant, it's all sorted. And then you look down here, we've got some lucency at the glenoid here, and we've got an avulsed bone fragment here. So this is that Bankart lesion. You can get loose fragments into the joint space that can cause impingement. So really important that you assess the glenoid in patients with dislocation. Incidentally, we've also got a small subacromial spur there as well, which we'll talk about later. Okay, in terms of dislocations, the vast majority of patients with dislocations will have anterior dislocations. Approximately 96% of all shoulder dislocations are anterior, and that's to do with the makeup of the shoulder and the muscles and the ligaments, and it's just far easier to dislocate it anteriorly than posteriorly or inferiorly. It's due to trauma where the arm's abducted and in external rotation. And as I've said before, the humeral head, as it comes out, it often strikes the inferior rim of the glenoid, and it can lead to that fracture, that Bankart lesion. You can also get fractures to the posterior lateral aspect of the humeral head, where it smashes into the adjacent bone, and you can get an indent to the bone, or you can get fracture or avulsed fragments, and that's termed a Hill-Sachs lesion. And I've got an example of that later. So on the X-ray, anterior dislocations, they look medial. Okay, so it comes out and it can come inwards. So we've got the glenoid here. This is the humeral head here, and you can see clearly that it doesn't line up with that glenoid at all. So this is the AP view. This is a turned view. You can see it much more clearly here. It's not quite a full wide view, but it's turned. And we can see that that humeral head has come forwards away from the glenoid. That glenoid rim is fine. We're not seeing any Bankart lesions, and we're not seeing any fracture to the posterior lateral aspect of the humeral head, that Hill-Sachs lesion. We're not seeing any of that either. But on this patient where it's been relocated, we are seeing that indentation to that posterior lateral aspect of the humeral head with some sclerosis. So this is a Hill-Sachs deformity or a Hill-Sachs lesion. Personally, I don't like to use the term lesion, because often that's used in terms of describing more sinister pathology. You know, you'll hear it, or chest lesion, or bony, destructive bony lesion, and sometimes people can get the wrong idea and get confused with that. So I tend to call it a Hill-Sachs deformity or a Bankart deformity and describe it. But you will hear the term Bankart lesion and Hill-Sachs lesion used. So, but it's important to know that that's not a malignant process or a sinister process. It's purely related to trauma from that dislocation. You can get posterior dislocations, but they're much less common, as I've said, around 2 to 3%. And usually because of the makeup of the shoulder, because of the anatomy, you need some serious trauma to be able to posterior dislocate it. So you're talking major trauma, electric shocks, or sometimes epileptic seizures, fits. Can be difficult to spot, and what we're looking for is rotation of that humeral head into what looks like a light bulb shape on the AP view. The axial projections are much better for evaluating it. You can also get inferior dislocations, which are even rarer. Probably accounting for about 1%, probably even less than that. And usually due to severe abduction or direct force downwards, axial force down onto the shoulder. And you often get associated fractures of the greater tuberosity with those as well. But you don't often see them. You can get what's called pseudo subluxations, where basically you get a large joint effusion within the shoulder, and that can push down on the humeral head and make it look like an inferior dislocation. It's not. It's actually just that there's a big joint effusion from trauma. So you just got to be wary of that. With these, the inferior dislocation, it's completely displaced. And so we've got here a posterior dislocation. We've got this light bulb appearance to the humeral head. You see how that's rotated? We're not seeing element of the greater tuberosity. That's actually here rather than it should be out here, but we're seeing it here. It's rotated round. Sometimes you can get widening of the glenohumeral joint space as well, but it's only really when you do axial projection that you can evaluate the full extent of the displacement. This is inferior. So again, you can see this here, this inferior aspect of the humeral head doesn't marry up with the glenoid. And we're seeing it on both views. This is the top of the glenoid, this is glenoid here. And we can see that this humeral head has moved inferiorly. Again, no associated fractures at the glenoid to be seen. No associated fractures at the humeral head. We've got another example here again. We're looking at this here, underside, doesn't marry up at all with the glenoid. We do have a large joint effusion there as well, so sometimes you can see where some of these fat pads get displaced. This lucency here, we can see there's increased density here, so that signifies fluid within the joint. The glenoid is up here. The humeral head's moved inferiorly. And you can also get other pathologies. So you can get calcification within the rotator cuff. So this is due to calcium hydroxyapatite deposition within the tissues. Commonly in the supraspinatus tendon. And I've got an image example of that coming up around the lateral aspect of the humeral head, coming over the top. And you can also get subacromial spurs as well, and they can cause impingement and pain. We can see here we've got this arc of calcification here within the acromiohumeral space. Often get this with chronic rotator cuff disease. You'll see the term calcific tendinitis used sometimes in indications, but that's not technically correct. What happens is when you get calcific tendinopathy, so calcification within the tendon, like we've got here, sometimes that can irritate and inflame the tendon, okay? And that's calcific tendinitis. But you can only say that on ultrasound. You can't be saying it just on an x-ray. So all we can say is there's calcification within the tendon, so calcific tendinopathy. With chronic rotator cuff disease, look out for sclerosis at the underside of the acromion and superior to the greater tuberosity. You can also get narrowing of the subacromial space. So again, you see this here. The underside of the humeral head marries up nicely with the inferior rim of the glenoid. This would be up here somewhere where that joint space is narrowed. So just keep an eye out for that as well. And to finish off, guys, we've also got a large subacromial spur coming around here. Just beware, though, of the projection, because sometimes the acromion, as it comes over, can simulate this appearance, depending on if the patient's rotated or the angle of the x-ray. So just be careful of that. Just be mindful of that, and just look to see if there's any different views. Just look out for it on there, for a Y view, for instance, or a turn view. Just have a look, double check on there before confirming. But this one, definitely you can see there's a big bony spur coming out there, so that could be causing impingement. Right, guys, so that's the end of this one. I hope that you've enjoyed it. I hope you found it useful. As I say, I've not gone into any major detail there. It's mainly for students and newly qualified. But if you've liked it, please drop us a like, subscribe to the channel, share with your colleagues, and give us ideas for further content. I'm trying to keep it simple to begin with, really. And just, I might do a few more videos going over some key areas, just with a few little bits and pieces. But if you want me to go into more detail on a specific area, specific pathology, specific body part, then just drop us some comments, and I'll be happy to do some more tailored content for you. But for now, guys, thanks very much for listening. I'll see you soon. Bye for now.